the Medicare beneficiary and provider training. This particular segment is for the provider topic. And the way we do this training is that we actually have different segments that we talk about. In this particular segment, we're going to focus in on the business processes as well as the systems. My name is John Beckett, and I am a trainer that has done a number of classes here at CMS. I've also been working on contracts here for roughly about 17 plus years and have a lot of institutional data knowledge about the CMS data. Here with me also is Ramesh Panada, and Ramesh has also have a lot of experience, and he's going to be featured on one of the other modules, training modules. But our lead instructor today is what's your name again? I'm sorry. My lead. We're going to edit that. My lead. I knew what his name was. I was just my lead instructor today is Carter Crawford. And Carter, why don't you tell the audience a little bit about your background?
Yes, hi, this is Carter. I have worked for over nearly 40 years in Health and Human Services in the Bureau of Primary Health Care, working with rural health clinics and the Health Resources Services Administration. Have been here at CMS working with John and others on master data management over the past, 5 or 6 years now. Mm-hmm. It's been. And so it's CMS is a very dynamic and exciting ecosystem, and look forward to chatting with you about the provider aspect of that today.
Great. So what we have here today, Carter, is we're going to focus on the provider topic, and I understand you have a lot of material you're going to cover, right?
We do.
Good. So why don't we go ahead and get started? I'm just going to again reiterate our objective for the class. We want to have the folks walk away with a good understanding of the provider data systems that support the Medicare program. There's quite a few that we want to cover. We also want to make sure that you walk away with an understanding of the provider subject areas relating to subject areas, identifiers, entity relationships, as well as data attributes. In terms of our agenda, we are planning to provide you up front with an overview of the Medicare provider business process overview. I just want to reiterate that this is focused on the Medicare program, this particular module. We have a separate module that we cover Medicaid, and we have similar, again, approach to that module. In addition to this agenda today, we're going to cover the primary Medicare provider data systems. And those are listed here. At the top of the list, we have NPES, which is the National Plan and Provider Enumeration System. We also have what we call PACOS, which is the Provider Enrollment Chain and Ownership System. We have another system called NPICS, which is the NPI Crosswalk System. These are primarily the three major provider systems of record that CMS has within their environment. In addition to that, there's some other systems that support these data systems, these system of records. The Master Data Management is one of them. The Integrated Data Repository, IDR, is what it's known as, which is also sometimes supporting the one program integrity. It's sometimes referred to. And then there's also the Medicare Claims Processing Shared Systems. So these, again, are all in support of those three major system of records for provider. Okay, I'm going to go ahead and turn it over to Carter, and if you can give us a little bit on the business process.
Thanks, John. Yeah, this will give you a 30,000-foot view of the overall processes around providers working with CMS and the Medicare program. And we'll just walk through it quickly from left to right. As you see, and as you've probably heard, if you had a chance to view the Medicare overview, there's several parts to Medicare, and you'll see here on the left is Part A, which tends to deal with institutional providers, the hospitals, for example. And then there's Part B that deals with your group practices, your primary physicians, your primary care providers, as well as suppliers. To start into being enrolled as a provider in the Medicare system, you begin with enrolling in the NPES system to get assigned a national provider identifier. The NPES system, which we'll unpack a bit later, is the system that was set up to correspond and respond to the legislation that required all providers that were doing HIPAA related transactions in the country to have a national provider identifier. And the reason behind that was there were many, many different providers associated, or identifiers associated with providers historically. And this was an attempt to try to deal with that disparity and diversity of identifiers and to try to organize it around a central, unique, and universally accepted identifier. So the first step is to get an NPI, and then you can go into the PACOS system that allows you to enroll, actually apply to enroll in the Medicare program. And as you see here, you can do it a couple different ways. You can do it electronically through the PACOS PI provider interface, or CMS still accepts paper forms. There's a number, you'll see these 855 A, B, I forms on the left here. Those are the paper enrollment forms. And about 50% of the applications for enrollment still come in on paper.
So Carter, quick question. You mentioned two systems here. A physician, in order for them to get an NPI and get into the Medicare program, it's required that they go through both systems. They have to first.
That's correct. And we'll talk about, you have to start with the NPES system to get
Okay.
NPI first.
All right.
Because to enroll in the Medicare program as a provider, you have to now have an NPI first.
Okay.
So we're going to drill down on that in some of the slides that we'll be chatting about.
Okay.
And all of this application processing and enrollment processing is performed by Medicare contractors that are positioned in what's called Medicare administrative centers that are distributed around the country geographically. CMS divided the country geographically into regions. They're called jurisdictions, and there's contractors that run these data centers around the country geographically and support the enumeration and enrollment. And as you'll see as you go to the right here, after enrollment, obviously one of the things you get once you enroll in Medicare as a provider, you get basically a bank account or a billing account that allows you to submit claims for the services that you provide as a provider to a Medicare beneficiary. And you can submit those claims typically electronically. And these MAC or Medicaid, Medicare Administrative Center contractors will take those claims and adjudicate them and process them. And if they are considered accurate and legitimate, they will generate a payment back to your organization or to you as an individual practitioner if you happen to be a sole practitioner or a sole provider. So as you walk out to the right here, you'll see there's a box here about PACOS AI. That's the administrative interface that the Medicare Administrative Center contractors use to manage the enrollment process. The data from this is then sent on to the claims processing systems, which are on the far right here. The claims processing systems are broken into several components. There's a component that deals with Part A claims for institutional organizations such as hospitals. There's a component that deals with the Medicare Part B, clinical and physician bills. There's a component that deals with durable medical equipment suppliers as a separate part. And all of this data is then extracted into various data warehouses and downstream systems that either look at program integrity or look at mastering that data for the sake of research, or that look at productivity and return on investment in the Medicare program. So this gives you a brief overview of the business processes associated with how a Medicare provider interacts with CMS and some of the key systems that a provider and that CMS uses to work with providers in the Medicare program. What we're going to do in the next 3 components of this session is to drill down on these 3 key systems and then chat briefly about some of the downstream support systems that master, utilize, and try to look at integrity activities around the data that's produced in this Medicare provider business process. So we'll stop here.
Yeah, just I'm going to record a couple questions.
Okay.
So Carter, is it true that if a provider doesn't have the access to either one of the NPES or PACO systems, they can still enroll? And if so, how would they do that?
Yes, you can still use paper.
Okay.
It's still possible to use paper. There, obviously, the desire is that providers use the electronic systems that are available online, and we'll chat about those a bit. But as we said with the enrollment, about half of those still come in on paper. So it's you don't have to have, if you're in a very rural area, for example, that doesn't perhaps have high-speed internet access, it may be your only option. And you can certainly work with the associates, as they're called, in the Medicare administrative centers, and they will work with you on helping you complete and get your enrollment process approved.
Great. One more question. I was wondering, does every physician have to have an MPI? And is that required for every physician to have an MPI?
Good question. Excellent question. There are providers of care that do not have MPIs. The HIPAA legislation was stipulated that if you're going to do a HIPAA transaction, and it specifies in the legislation what those kinds of transactions are, then those providers are required to have an MPI because those transactions are processed electronically, and they're trying to use the NPI to verify that the provider that is providing the service has been reviewed, has been approved, meets certain standards for providing services to Medicare beneficiaries. There are, however, to John's question and to his very point, there are a few providers, both in the Medicare program and in the Medicaid program, quite a few more in the Medicaid program, that do not have MPIs. Some of them are historical, and some of them are not actually required. Now that's over time, obviously that's changing. Both in the Medicaid program and in the Medicare program, the encouragement is to move toward getting an NPI, so that you can participate in these programs and that your claims can be processed quickly, your reimbursement can be received more quickly, and so that you are clearly identified as someone that has been vetted, and that there's And part of that vetting is to make sure that Medicare beneficiaries are receiving the quality of care that they deserve.
Okay, great.
So, Carter, so if a provider doesn't have an NPI, can they still submit claims to CMS?
Good question. They can, but it would have to be a separate process.
So it's
because
totally not part of this.
it would not
ecosystem.
be part of this, because if you're submitting a claim that's a HIPAA transaction and you expect to be reimbursed, then as the legislation is written and as the systems operate currently, you would have to have an NPI. Now, again, we said previously that there are a few that don't have NPIs and yet are in a special category that are still, their claims, there are special provider categories that are in special programs that aren't required to have an NPI. And yet the billings associated with their services are usually covered by organizations or by providers that do have NPIs. So they tend to be associated with or part of a NPI associated organization or provider.
Okay, great. We're good.
Okay, in this segment, we're going to drill down on 3 of the key provider data systems that support the Medicare program. And these 3 systems, as John mentioned earlier, are the NPAS system, which assigns a national provider identifier to a provider, the PACO system that allows you to enroll in the Medicare program, and the National Provider Identifier Crosswalk System, the NPI crosswalk system called NPICS, which we'll talk about why that exists. And then there are here a list of downstream systems that use the data that's created and managed by these 3 key systems at the top. Master Data Management is a initiative by CMS to try to master data, not just within Medicare, but across Medicare and Medicaid. We'll talk briefly about that later. John mentioned the integrated data repository and the 1PI project that's working with IDR to try to make that try to make that data repository more business friendly and to integrate the data that's in the IDR in a more useful and in a manner that has a bit more relational integrity. So we'll chat briefly about that as well. The claims processing systems are called the shared systems at CMS, and as we mentioned earlier, they're broken into 3 segments around 3 different parts. Fiscal intermediary system deals with institutional claims like hospital claims. The multi-carrier system deals with Medicare Part B claims, and the VMS shared system deals with the durable medical equipment and supplier claims. There's also an exclusion database that talks about, that makes sure that providers that, for whatever reason, have legal sanctions against them are excluded from being, their claims being processed and then being reimbursed. And it tracks those legal sanctions and any kind of exclusions. The national level repository is another system, much like the IDR, that deals with a lot of claims processing and is a repository that allows some claims manipulation and statistical work. And then there's a DBID system that deals with the bidding around durable medical equipment suppliers. And there's a whole series of legacy systems as well that historically were used by the shared systems, the claims processing systems, to process claims, Medicare claims. And what we've done here is listed some of those legacy identifiers that the fiscal intermediary and the multi-carrier system and the VMS system still use to process claims. And we'll chat a bit more about those as we get further along here. Again, this slide tries to unpack a bit about the diversity of identifiers. The whole reason for the National Provider Identifier and the HIPAA legislation was to deal with the fact that historically, providers had just a plethora of identifiers, depending on which programs they were involved in, what organizations they were associated with, the kinds of services they provided. They could have 5, 6, 7, a dozen different identifiers. And those only grew as time went on. So there was a need to try to coordinate this. So the HIPAA legislation was designed to assign one national provider identifier to a uniquely identified provider. And I need to unpack for you just briefly what a provider means at CMS, because you're going to hear a lot of terminology used at CMS that you may or may not be familiar with. The term provider, this is a bit of a sidebar here, but the term provider is a term that covers a number of different components. One is an individual practitioner, for example. You might think of a new doc that just graduates from medical school as an individual. You have institutional providers, such as hospitals, that are termed as institutional providers. And then you have a third group that's called suppliers. Under suppliers, you have durable medical equipment suppliers, you have group practices, you have clinics, you have chain organizations, most of which work under the Medicare Part B component, but could work across Medicare Part B as well as the durable medical equipment. So you'll hear the term provider used to cover all three of those classifications of providers. The NPI is assigned to either an individual practitioner or can be assigned to a subpart of an organization. Take an organization such as Walgreens, a chain organization that has over 8,000 stores. Each of the stores in the Walgreens chain has their own unique separate NPI because each of those stores independently provide durable medical equipment and Medicare Part B supplies to Medicare beneficiaries. So again, the NPI is becoming a very important and a key identifier that crosses not just Medicare, but is also increasingly being used and implemented in the states for Medicaid. This is a way that we can now tie together providers that work both in the Medicare and the Medicaid program. Just quickly, there's a number of additional historical provider identifiers. The National Supplier Clearinghouse, for example, assigns unique numbers to the durable medical equipment suppliers. There's certification numbers where CMS actually goes out and does site visits and certifies that a particular service delivery location meets a set of standards to ensure that Medicare beneficiaries are receiving the quality service that they deserve, and that these service delivery sites, in fact, meet a certain set of standards. There's a number of other historical and identifiers that are still used. The PTAN, the Provider Transaction Access Number, is a key identifier that identifies the bank accounts or the billing accounts, if you will, under Medicare, and those are used actively in the claims processing. The UPINs, the Medicare Unique Provider Identifier numbers, are historical numbers, as well as their OSCR numbers, for example, as we talked about, up above here, Oscar numbers are actually being replaced by the CMS certification numbers. And then there are CLIA numbers that deal with laboratories, FDA numbers, DEA numbers, Railroad Retirement Board numbers, and a whole bunch of others. So the challenge to CMS was, how do we deal with all of these different identifiers, try to link them together uniquely to a particular provider so that we can uniquely identify and process a claim for a provider. So this gives you an idea of some of the plethora of identifiers associated with Medicare providers. Excuse me. The NPI was mandated in 1996 through the HIPAA legislation. It's a 10-digit number. You can always tell if it's an NPI number because it starts with 1. If you see a 10-digit number identifier associated with a provider that doesn't start with a 1, you know it's not an NPI. There are some special cases where CMS will deactivate an NPI and assign a new one to a given provider. And so there are cases over time where an individual or an organization or organizational subpart can have more than one NPI over time. Sorry, we're going to have to break because I'm going to have to get some water here.
Okay.
Apologize. My sinuses are giving me a run for my money here in the fall. So I'm going to pick back up about the NPI and so in special cases such as identity theft and fraud, or a provider can make a special request, CMS will assign a new NPI. It is the case by policy, however, that a provider cannot and should not have more than one concurrently active NPI. There's over 5, goodness, I'm sorry.
That's okay. Take
Try
a
again.
break. Take a break. Yep.
So I got some bagels just for you guys.
Okay.
Not bagels, but donuts.
We'll break. We'll break.
Sorry, guys.
I need something
It's
so
okay.
you can clear your mouth too.
My sinuses with in spring and fall, my sinuses go
Yep.
crazy, and then
Take a swallow of
my
water.
voice will.
Yeah,
will-
keep
will
the
go
water
up.
going down the pipes.
Yeah.
That
Problem
helps.
is if I drink too much water, then it closes up.
Eat so that it might clear your thing.
Yeah. Good. Thanks.
I didn't know if you guys eat eggs, so I just got those.
Mm-hmm.
You okay? Hot coffee or something?
No, it's mostly these things I have to chew on and then
So that helps
clear up.
clear it up.
are we
We're okay. Don't worry about it. Don't worry about it. We're
kind
okay.
of going slow here, but
Yeah, I think the pace on this slide, if you keep the bullet pace, then I think we're good.
I'll try not to elaborate too
And
much.
yeah, it's okay. I mean, if there's a point that's good to elaborate, go ahead and into it.
Yeah, the one that I liked is once you're done the questions,
Yeah,
that's really good.
yeah, I think so too.
Yep.
Yeah, I
Yep.
think so too.
Okay. Let's see if we can start again.
So we're right at the.
Enumerate, how many,
Yep.
okay. So we're gonna pick back up here. NPES has enumerated over 5 million, so there's over 5 million providers that have been assigned NPIs by the NPES system. There are 2 types of NPIs in the NPES system. Type 1 is for individuals and sole proprietors, and that's about 70% of them. And then there's a type 2 that's associated with organizational providers, and that makes up the remaining 30%. Now, a key part of that you need to appreciate about organizations is an organization such as a hospital typically has subparts or departments. And each of those departments, such as a outpatient department, emergency room, ambulatory center associated with a hospital. Each of those will have their own NPI. And organizations actually have opportunity to designate subparts as they will. So again, a hospital typically will have many, many NPIs associated with it. And each of the departments under that hospital will have their own unique NPI, even though all of those departments and all of those subparts all share the same tax identifier because they're all parts of the same organization, same entity. So we'll chat a little bit about that in a bit as well.
So can I ask a question here?
Sure.
So once an individual or organizational provider gets assigned with an NPI, are there any scenarios where the NPI can change?
The NPI, good question. The question was, are there scenarios where an NPI can change? As we set up above in the middle of the screen in special cases, there are events that can occur that would require, where CMS will either deactivate a provider's NPI if they were in a legal case, for example, and the fraud was, there was fraud involved, perpetuated by that particular individual, they would bar that provider from working with the Medicare program and might actually go to the point of deactivating their NPI. Typically, NPIs are deactivated when there's a case such as identity theft, where someone will steal a provider's identifier, use that identifier to submit fraudulent claims, and in order to clear the slate, if you will, associated with that NPI, CMS will deactivate that NPI that was stolen and assign a new NPI to the innocent party, the provider whose identity was stolen. Again, a particular provider should only have one and only one NPI active at any point in time. And the idea is that NPI stays with that provider perpetually throughout their entire life. So that's the more common scenario, is that once you're given an NPI, you keep that and use that, and that's your unique identifier forever. In case the only other scenario would be if there's one of these events that would compromise your identity, then they will assign you a new one and deactivate the old one. And that brings up some interesting scenarios in terms of time framing on identification of a provider using the NPI. So you need to know and appreciate the fact that it's possible that a provider over time might have more than one NPI. Mm-hmm. But at any given point in time, they should only have one active.
So not to go into too much detail, when a provider has been assigned with an NPI, is it associated to provider's demographics, or if a provider moves from individual practice to an organizational practice, will the provider still retain the NPI that was assigned to him?
Good question. Let's talk about an individual practitioner that's associated with a group practice, or maybe goes to work for a hospital, or maybe he or she is a radiologist and works with 20 or 30 different hospitals or organizations around the country, which is often common now with telehealth. A radiologist will sit at home and review images and be subcontracted to any number of hospitals or organizations, not just in their state, but perhaps across state boundaries. Just because you are associated with an organization or another provider does not change your NPI. The NPI is a unique identifier, similar for an individual practitioner, similar to a Social Security number. It is a unique identifier for that individual. The NPI is also a unique identifier for a subpart of an organization. So, for example, a particular store, pharmacy store in the Walgreens chain that has 8,000 plus stores, each store, which is a physical location, has a unique NPI, and that NPI stays with that store until it's shut down. Even if it was shut down and moved across town and Walgreens assigned it the same number, same identifier, in the Walgreens chain, it would keep its NPI if it was still the same entity.
Okay.
So the idea is that the NPI stays with you.
So that brings up one more interesting question. So you said that sometimes it could be a social security number as well, maybe?
I'm sorry?
You said sometimes the NPI can also be a social security number?
No, I'm sorry. You know, I was making the analogy that the
Okay.
NPI
Okay.
for an individual practitioner is similar to a social security number
Similar to-
because it's
got it,
something
got
that's
it.
uniquely assigned to you and stays with you ideally for life. Except in the scenarios where someone steals your identity, IRS typically doesn't assign you a new social security number, but CMS might assign you a new NPI.
Okay. Just one more question. Because HIPAA, the Health Insurance Portability Accountability Act, pretty much mandated this because of the financial and administrative transactions, which, by the way, could go between commercial organizations
Yep.
as opposed to having to go with government. If I am a provider who doesn't have any plans on working with Medicare or Medicaid, I still am required to have an MPI. Is that correct?
Only if you're doing HIPAA transactions, which are stipulated in the legislation.
Right.
So if you're not doing any of those transactions, you're not actually required
Gotcha.
to get an NPI.
Okay.
And there's many providers in the Medicaid program that do not have NPIs because they're only working in state Medicaid systems or in CHIP systems. Now, the states, as we will talk about when we get to the Medicaid provider area, the states are systematically moving toward adopting the NPI, and that process is maturing.
Okay.
But there's still a number of states that do not require their providers that only work in the Medicaid CHIP program to have an NPI.
Got it. Okay. All right, let's move on because I think we're, right?
Yep. Okay, I want to drill down just a little bit on the NPES data and give you just a brief overview of what's there. The key aspect to the NPES system is that it's a one-level system. There's one record per NPI, and all the data associated with a provider is at the NPI level. And so you can think of it as one row per NPI, and all the attributes associated with a provider are stored associated with that NPI in columns of that one row. So at the top here are some examples. One of the key aspects of NPES is the dates. There's only two dates in the NPES system. There's a date for the effective date of the NPI, which is the date the NPI was assigned. And there's a separate termination date that indicates when that NPI was no longer effective. There are no other dates in the NPES data. But there's a whole lot of other attributes associated with the provider in NPES. The name, for example, is there. The credential, the date of birth, the tax ID. There's a whole list of fields available for Medicare identification numbers, legacy numbers, PTANs, Oscar numbers, an entire list. There's taxonomy codes. None of those have an effective date associated with them. So the key thing to note about NPES is if you want to know the information associated with provider in a point in time, the only thing you can be assured of in NPES is that what is shown in terms of the effective dates is only related to the NPI. So for example, the first row here, Christine Schaefer, if Christine got married and changed her name to Christine Jones, unless, and it would be her responsibility. It's the responsibility of the provider to go in and update the NPES record. If she didn't go in and update the last name to Christine Jones, it would retain Christine Schaefer, and that's what would be there. And if she did go in and change her name to Christine Jones to indicate that she had changed her last name, there's no place in the NPES record to indicate the date on which that name became effective and the date that her prior name was no longer effective. So that's a key aspect of NPES that you need to appreciate. Its focus is enumeration of the NPI, assignment of the NPI, and the dates associated with that. But there is a variety of other information. As you see here, there is a publicly accessible registry website that's circled up here at the top left. You can go in and query the NPES data at a name level, either organization or individual. You can use parts of a name. You can use a taxonomy. If you know the NPI number, you can type that in. And you can look it up by type or any type. You can look at a particular state or county or even a postal code and try to identify providers that have been enumerated and assigned an NPI based on any of these selection pieces of information. Now let's move on to the next slide. Unfortunately, I didn't provide an example here of what comes out of this, but you'll please go and take a look at the NPI registry website, and I think you'll be amazed at the amount of data that's there. There is not only the enumeration information, there's information about mailing address, about a practice address, about the organization with which the individual works. There's taxonomy codes, there are specialty codes, there are a whole list of legacy identifiers, not just Medicare identifiers, but Medicaid and indeed private insurance identifiers. Whatever the provider decides to list in their NPES application, they can include it, and you will see that on the NPES public registry. Now, the public registry does mask some information like Social Security numbers and dates of birth and some of the information that's more individually identifiable. So take a look at that, and I think you'll find it very useful. Now, all the things that we're talking about today about the NPES system, the PACO system, and the NPIC system, CMS is a very dynamic environment to the point that all of these key systems for Medicare are all in flux. They're all being redesigned, they're all being updated, and Congress could come out with new legislation tomorrow that would cause them to have to adjust and change again. But NPES is being redesigned. There's a 3.0 enhanced version that's going to be coming out soon, toward the end of 2017 or early 2018. And there's been a call, for example, because there's a great expanse of information in the NPES system, but only small parts of it are date stamped. There's been a call to begin to date stamp more of that information and to provide additional information about things like addresses or subparts of organizations. For example, now you can only list one legal business name and one doing business as name. I believe they're going to expand this to include multiple doing business as names and multiple practice location addresses, where currently there's only a slot for one. So I won't go through all the details of these intended expansions, but just be aware that NPES is being updated and enhanced, so look for those changes in the near future. So that's going to end our segment on the NPES system, and our next segment we'll begin to move on and talk about PACOs.
Okay, let's take a break for a second. All right. So I think we're going at
Just
a
are
pretty
we drilling
pretty
down
good-
too far?
Good clip. I think we should
Move on.
bring it up a
Okay.
level.
Okay.
And you gave them a pretty good tease in terms of the depth that we could go to. And so, yeah, if we just bring it up a level,
Okay.
then we'll be
Yep.
able to speed it up a little
Okay.
bit.
Yeah, I'll,
And then also, if you can interject every once in a while that we offer more detail in one of our other courses, and
okay.
so you can just kind of let them know that you can go into more detail, but we offer that in one of our other courses.
The other courses.
And it's just kind of an advertisement
Yes,
kind of thing.
okay.
For time, we're at 9:15.
Yep, yep,
Let you know.
yep, okay. All
Okay,
right,
we better
so,
move on.
yep, ready to go? Go.
Okay, in this segment of our session, we're going to drill down a bit on the PACO system, the enrollment system. Again, we're doing this at a pretty high level. There's a lot more that could be said and a lot more that could be unpacked about these systems. And there will be subsequent training sessions that will be available to you to learn more details about these systems. So again, we're trying to, the intention of this training session is to hit some of the high points. PACOS is the online system to enroll providers in the Medicare program. And as you can see in this diagram, you can either do that electronically through the online PACOS system, through a web browser, or you can send in a series, one or more, what are called CMS 855 forms, manual forms, to the local Medicare Administrative Center. That's what the MAC stands for. And a person at the MAC will enter the enrollment information off the form into the online system. PACOS does verify and does validation on the data, the information that's entered into the applications at a deeper level than is done at NPES. It really didn't talk about validation activities on NPES. They do, most of the data in the NPES system is self-reported. In the PACOS system, yes, the application is self-reported, but they do a number of validation exercises. For example, they do site visits. You'll see at the bottom here. They actually work with regional offices and state contractors to go out and visit the sites where services will be delivered to, again, ensure that, number one, the site exists, and number two, that it meets a certain standard of quality for delivering services to Medicare beneficiaries. So there is a set of verification activities that's done at PACOS at a much deeper level than the data that's reported, self-reported in the NPES system. The enrollment data is then passed down to a number of downstream applications that primarily use this enrollment data for claims processing. Once your application in PACOS is approved, you are assigned a Medicare identification number, or what's called a PTAN now, which is basically a billing account. It's a bank account that allows you to submit claims to Medicare for the services that you deliver and to be reimbursed based on the claims associated with that billing account. And then on the far right here, under number 6, you'll see the PDAC and VMS, a number of other downstream systems that look at integrity of claims, that look at performance, and deal with other aspects of program integrity, quality. There's a quality system that looks, there's other downstream systems that we'll mention later on. So let's move on. This is a high-level overview of how a provider will enroll in PACOS. And again, you need to enroll in PACOS, you have to get an NPI first. So at the very far left, you'll see that the NPI is a requirement now to go in and enroll in Medicare. PACOS is the system the one and only system that manages the enrollment process for all the providers and suppliers that bill the Medicare fee-for-service system or that order and refer services for Medicare beneficiaries. It's the system that's used to both enroll, manage, screen, and revalidate providers. There's a revalidation process that CMS goes through periodically to verify and validate that the information that they have in the enrollment system is current and is accurate and is complete. PACOS is the system of record for all the Medicare provider enrollment system. It captures legal entity information, it captures ownership information, anything and everything associated necessary around claims processing and the ability to be able to bill Medicare is based to primarily on the data that's captured in the PACOS system. Now, a provider can submit different enrollment, more than one enrollment. If a provider works in different states and those different states cross the geographical boundaries that CMS has set up for the Medicare jurisdictions, then they will have to enroll separately in those separate jurisdictions. So for example, if you're a provider that works in the Washington, D.C. metropolitan area, and you have an office in Maryland and an office in Virginia, you will have to enroll twice, once in the MAC associated with Virginia, and separately for the MAC that's associated with Maryland, because those are two separate jurisdictions managed by two separate Medicare administrative centers in the Medicare system. There's some basic statistics here. You see there's nearly 2 million, there's actually over 2 million active enrollments in PACOS now. You can see about half of them, it's a little more 60-40 on the online versus paper now. So as time goes on, the providers coming out of the school are more used to using electronic systems, and so they're systematically receiving more enrollment applications via the web and fewer by paper, but they still will process and do process thousands of paper applications. Okay, let's move on. This is a list of the enrollment forms. These are the paper forms. And in fact, it's a good way for you to get a good quick start overview of Medicare and the enrollment process is to look through these forms. You can go online to Google and query them and download them and look through them, and they're very informative and helpful because they explain exactly what a provider must have and must provide in order to enroll in the Medicare program. And as you can see, they're divided by different types of providers. Institutional providers use the 855A. These are organizations such as hospitals, typically. The 855B are used by clinics, group practices, and certain other suppliers. And here's the word supplier suddenly coming in to describe a provider. So again, I try to articulate some of the nuances in the terminology used. Again, the global terminology is all of these folks and organizations and subparts are all called providers. But within that, they are sometimes referred to as institutional providers, suppliers, DME suppliers, chain organizations, and so on. So you'll see those nuances actually described very well in these paper forms, these paper application forms. So again, it's educational to go through and look at these forms. The CMS 855I is for individual practitioners that are primarily billing Medicare Part B. And you can only have one NPI since it's for an individual associated with the 855I. And this is also a form that physician's assistants use to reassign their Medicare billing benefits to the organizations with which they work. And that creates an interesting scenario because as you see two more down, there's a CMS 855R that's a reassignment of Medicare benefits. This is the typical application form that's used by an individual practitioner to reassign their Medicare billing benefits to an organizational, either a hospital, for example, if they work with an institution, with a group practice, if they're associated with a group practice, or in some cases, they may reassign parts or of their benefits to a whole series of organizations with which they're associated with, both institutional providers as well as group practices. You can think certainly of an individual practitioner coming out of school, going to work for a group practice. The group practice is actually owned by a hospital. The hospital is part of a hospital system, or a pharmacist coming out of pharmacy school and going to work for chain organizations such as CVS or Walgreens. And would typically, they will not bill directly for their services. CVS or Walgreens will bill on their behalf. And so their billing benefits are reassigned from them as an individual to the organization. And then the 855S is a form that allows the DME suppliers to apply on a site-by-site basis. Each site in the 855S is associated with one and only one site, and each of these applications have one and only one NPI. One of the interesting things of the 855B, particularly for groups, is that there can be an entire list of NPIs associated with this one application. The Walgreens application is a case in point that has over 7,000 NPIs associated with one CMS 855B application. So again, some of these are required to have only one NPI associated. Others can have this relationship of multiple NPIs associated with that one application.
One of the key points to this, though, is if you want to understand the data and where it's coming from, these forms will let you know what data is being captured. So whatever data is in the systems, this is what's being captured, used to capture that data.
Good point. PACOS is very much designed around these forms. It's very much a form-driven system.
Okay.
But as we have said before, PACOS is also in the throes of being redesigned. So this may change, and we will have future training sessions that unpack and explain the changes that come with PACOS 2.0.
Okay.
I want to do a bit of a run through the PACOS administrative interface data model. There's over 1,000 tables in the data model, and frankly, obviously, we don't have the time to drill down on all of those. You'll see here some of the categories of tables of functional areas that are addressed in the model. The enrollment is the key to the kingdom. Most of PACOS is associated with and focused on an enrollment. There's this concept in PACOS that's unique to PACOS of a PACOS associate. And a PACOS associate can be an individual practitioner, can be an organization, can be a subpart of an organization, can be an individual that performs some role supporting a provider, and they are actually captured. For example, authorizing officials or owners, part owners of an organization are captured in PACOS. And they will be in the PACOS associate information and then associated with the enrollment in the particular role that they are playing in that enrollment. So PACOS is very much an enrollment-focused system and enrollment-focused data model. You'll see there's addresses, both mailing addresses, business addresses, practice location addresses. It's a whole series of identifiers captured, legacy identifiers and current identifiers associated with an enrollment. there's associations. So you can imagine you have individual practitioners, you have group practices, you have hospitals, you have chain organizations, you have organizations that own organizations, and all of these are related on a claim, but they're also related in the enrollment system in the various business associations that they established in response to the needs for service and in response to the needs of the beneficiaries and how they best want to organize to deliver the services for the Medicare program. So let's move on. We're going to drill down on a few of these. Obviously, we can't cover all of them. This slide gives you some of the key data relationships in PACOS. PACOS stores its data at 3 unique levels. The PAC ID level, this PACOS Associate Control Identifier, also known as a PAC ID. And as you see, that PAC ID is closely associated with the tax identifier that's assigned either to an organization as an employer identification number or an individual who would get a social security number. So the PAC ID correlates generally to the federal tax identification number. If you look on the right associated with an individual, you'll notice that there's an NPI box there, and it says NPI. It says there's one. There should be only one. As we talked about before, there are cases where that gets replaced, but there should be only one currently active NPI associated with that individual. That individual can, however, have a whole series of enrollments, and associated with that series of enrollments are PTANs, which are the billing accounts identifiers, with reassignments that this individual could be associated with over time with different organizations. They could be involved in different states, and they could be involved with different roles in different organizations. Of course, licensing information and other demographics associated with the individual. On the left side, you've got the organizations. Organizations, you'll notice at the top, it's MPIs plural. Many organizations, such as a hospital, a group practice, or a chain organization, will have a whole series of NPIs associated with that particular organization. So again, the example of Walgreens has over 7,000 NPIs representing over 7,000 individual stores in the Walgreens chain associated with one enrollment for the Walgreens chain in PACOS. There's a lot of relationship information in PACOS also associated with these enrollments, who owns the organization, who the directors are, that sort of thing. These organizations have legal business names that change over time, possibly. Also, they have doing business as names. For example, each of the stores in Walgreens is a separate doing business as name. It's a store with a store number. Those are all doing business as names under the legal business name Walgreens pharmacies. And you'll see that organizations can also have a whole series of multiple enrollments, and there's many subparts to those enrollments, and many individuals play different roles in those enrollments. So this gives you kind of an overview of some of the key aspects of the relationships in the PACOS data, but once again, going back to the top, the key here is that PACOS actually stores its data at 3 different levels: the PAC ID or the tax level, the PAC ID plus the enrollment, so this is at the enrollment level, and then below the enrollment, there's a 3rd level that lists the one NPI in the case of an individual, or the multiplicity of NPIs in the case of an organization.
Okay. All right, let's break here. So one of the things I want to do is I'm going to take some of the slides here
Skip some of those.
and skip them.
Okay, that's fine.
But what I'd like to do is have you do a commercial right now and
Okay.
say that there's a lot of information that we can go into around the relationships between the TIN and the enrollment record.
Okay.
To
I'm
the
going to drill
NPI.
down on that in this session.
Yeah, and I'm
Yeah.
not gonna show any of these slides.
that's
okay? And then, you know, you can talk about the reassignments and practice location relationships, the authorized officials. There's, you know, so in other words, if you could just list them
Yes,
or give a sense of them
yes.
in the commercial, that'd
And
be
we'll,
good.
and we'll
And then-
say we're going to drill down on these in
and we
a
can,
future session.
exactly, we can drill down into them in future sessions. So those four I'll skip.
Okay.
And we'll go right to here.
Go right there. Okay.
Yeah. So if you can, go ahead and do a commercial real quick
Okay.
and, just to ducktail the, relationship.
Okay. Speaking of the Pecos data relationships, there's as you can see on our slide here that we just reviewed, there is a lot of information and attributes associated with Pecos enrollments. For example, there are a number of relationships in the Pecos data dealing with the relationship of NPIs to tax IDs.
Okay, hold on for 1 second. I apologize.
Sure.
This was my problem, my fault. All right, I'm gonna go back to this
Yes.
slide. Go ahead and do it again. Just do
Okay.
the commercial again.
Okay. As you can see on this slide, there is a plethora of attributes associated with a Pecos enrollment. And we could spend a good bit of time drilling down on each of these attributes. We will do that in subsequent training sessions to help unpack more of the relationships in the Pecos data. For example, there is, with organizations are very interesting. The subparts of organizations, the relationship of NPIs to those subparts and those subparts to the EIN associated with an organization. Those all have ramifications, particularly when you have enrollments that may not list the same set of NPIs associated with this, with different enrollments that are all aligned with the same organization. So that can be, in a word, that can be complicated. And it is. And we need to have more time to unpack that. And we will do that for you in a subsequent session where we talk about the tax ID to enrollment to NPI relationships. We'll talk about the aspect of reassignment of benefits, for example, which is another key aspect of Pecos. And the kinds of information and things that are inherited by an individual practitioner associated with the organization as a result of reassigning their benefits to that organization.
Okay.
We'll talk about that in a future session.
All right, great. Just break right there.
Okay.
All right. Okay, now we can continue.
Okay, as we've mentioned, all of these systems are in the course of being redesigned at CMS. Pecos is currently being redesigned. A Pecos 2.0 is planned to be developed, finalized, and brought online sometime, hopefully in 2018. Again, Pecos currently is very focused on enrollment, and there's some thought that it needs to be more focused on the PAC ID or the tax ID or the individual or the component of the organization itself, and that the enrollment focus needs to be adjusted a bit. So that's in play as we speak. Therefore, we will need to have a future training session that unpacks the new Pecos once it's brought online and informs you of the changes that are taking place. There are some limitations in the current Pecos data. For example, Pecos does not currently contain a list of all the programs that a particular entity, be it an individual or a subpart of an organization, is participating in or affiliated with. For example, the opportunity for the alternative payment model initiatives that are going on in the Innovation Center at CMS. That's opening up a whole new set of relationships between providers and organizations and subparts, and that's not really captured in Pecos. And so the question is, should Pecos be the place that begins to capture more of that information? And that's part of what is being considered in the redesign. Hospital affiliations, Pecos doesn't maintain a link between the hospitals and the individuals that work for them or within them, particularly those that don't have a reassignment to a group practice. The reassignment of benefits is supposed to give you that view, but it's not always clear that everyone that should have a reassignment of benefit actually has put in that application and it's been reviewed and is in place. So there's some aspect of hospital affiliations that's not always entirely clear. There are some historical providers. There aren't many, but there are some historical providers in Pecos that do not have MPIs. There's actually some current providers in Pecos that don't have MPIs. And the folks in PAYAG are actively working to try to make corrections and adjustments to make sure that there is an MPI recorded for every provider that is in Pecos, so that there's relational integrity within the data model. There's also historical, the Medicare administrative centers are run by contractors. And as you know, contractors change over time. And so if a historical contractor is replaced by a new contractor, the contractor identifier in PACUS needs to change. And historically, what would happen was that all of the Medicare identification numbers, or PTANs, or if you will, Medicare billing accounts that were assigned by the prior contractor would be terminated, would be deactivated, and the new contractor would assign new ones. They've gotten a little less rigorous about that, and what has happened is that they've just changed the contractor identifiers. And so some of that history about who was the contractor that was really responsible for managing this historically it doesn't always exist in PACOS. Some of that only exists in the NPICS archive file, and therefore it's not available in PACOS. So there are some known limitations in PACOS data.
Okay, break there for a second. All right, so we're gonna skip this next one, but I'd
Okay.
like to do a commercial here again. So the commercial is basically to ducktail this. In addition to these limitations in PACOS data, we also are looking at providing you with a lot of detailed information about the differences between the two systems I've already talked about, PACOS and NPES. And so if you're interested in that kind of information, we have another training module that you can sign up for that will go into depth about that.
Well
Okay.
said.
Yeah. Okay, well, maybe that's a commercial. Maybe that's the commercial.
Do I need to repeat
So maybe
that, or
that's
I
maybe
think-
that's
I
the
think
commercial.
You said it. Do you
Okay.
think that's sufficient?
Can we work with? We probably can work with that.
I can
Okay.
restate it if you want. But,
Why don't you do that and just ducktail this one here?
okay.
Yeah.
Uh,
In addition to
In addition to the limitations in PACOS, we want to let you know that there's some, we want to unpack for you some of the nuances between NPES, PACOS, NPICS, and the other downstream systems in the Medicare data systems. There are nuances. For example, in the NPES system, provider names are upper and lowercase. In PACOS, they're all uppercase. Well, that seems like a minor thing until you want to query or show that on a particular piece of correspondence. For example, you may want it upper and lowercase. There is variations in the way names are entered sometimes in different enrollment records in PACOS. And so that creates some interesting scenarios. We talked previously about NPES not really reflecting a change in a provider's name. There's no way to know there's only one slot for the name, and so if the name changes, they simply just type over it. In Pecos, however, you'll have the historical name as well as the current name. So these sorts of nuances between NPEZ and Pecos are sometimes of interest and certainly important, and we'll unpack that for you in a future training session.
Okay, good. Not bad. Yep, okay. All right, so now we get into NPICS, and let me just take a look at what we've
Okay.
got here.
So the
So-
first one is about just sort of an
Just the
overview of
overview,
what
which-
it is.
We'll definitely do that
And
one.
then this flow kind of explains how it works.
Yeah.
You know, at a high level, that
Yeah.
what its purpose is and the reason it was created to begin with.
Yeah.
The historical context.
Yeah.
And then from that, I start to go into the data model. Now, I'll probably not drill down very much on this, except to say that these are the two key tables.
Okay,
The provider identifier table
Okay.
and the provider cross-reference table. Those are the two key tables. But as you can see from the first slide, there's a number of other attributes that are tracked in NPICS.
okay.
And then
Can I suggest right here
we
is
may
where,
want to skip some of
yeah,
these
these two here we'll skip, and
because
I'd like to say we have a whole separate NPICS module that goes into detail
Fine.
about NPICS and the data. So if you're
Gotcha.
interested in that, we
Gotcha.
can go ahead and,
yeah, because that gets pretty
yeah, so
detailed.
there's 4 NPICS slides, and
We have
let's,
12 minutes.
how much?
We have 12 minutes.
Okay,
10 minutes? Okay.
so let's see if we
So
can
we
get
need to
through.
pick back up like with next week on
Mhm.
a continuation. We
I'm
can,
with you.
I'll just work with you to try to get some time so that we can, so wherever you feel like a good point to end,
Yeah,
then we can just
yeah,
end there.
we'll get through these 4,
We'll finish
and
this up.
then, yeah, we'll see if we can finish these up. So let's get through these 4 here. Okay,
Okay, we're now going to chat briefly about the NPICS system, which is the third of the 3 key systems in the Medicare provider data system. The NPI, as we've talked about, was mandated in 1996 by the HIPAA Act, and it's required as the sole provider identifier on all HIPAA electronic transactions. And as you can see, there was a transition phase, and that is still occurring, particularly in the Medicaid program. States are still working on adopting and interfacing and integrating the NPI into their systems. So key identifier, the problem that the NPI created was that CMS had a very large and very intricate claims processing system, a fee-for-service Medicare claims processing system that is composed of millions of lines of COBOL code. And so when the NPI comes along, the question is, do we at all, the risk associated with going in and trying to change those systems to accommodate the NPI was too great, was incredible, because there's so many rules, business rules, written into the coding, into the shared systems. So the idea was, hey, let's avoid that risk by creating a crosswalk system that simply crosswalks the new identifiers, these new NPIs, to the old legacy identifiers that the COBOL system already knows about. So that's exactly what they did. They created the NPI crosswalk system, commonly known as NPICS, to do just that. Okay, here's the NPI for this provider. Well, here's the list of legacy identifiers that historically have been associated with this provider. And these are the legacy identifiers that the billing claims processing system understands. So when we send this claim on to the claim processing system, instead of sending the NPI, we're going to send the legacy identifier that the claims processing system already understands associated with this NPI. That was the reason, the purpose, the whole rationale behind the NPICS system. Now, NPICS was always intended to be a temporary solution to the problem. CMS has announced that it's going to retire NPICS next year in 2018. So this is having an impact, as you can imagine, on many of the downstream systems in CMS. So let's move on to the next slide. This slide gives you an overview of how NPICS works. The PACOS is the enrollment system. It sends its enrollment information to the MACs, the Medicare administrative centers that actually process the claims. In fact, the people in the MACs use the PACOS system to manage all of this data. So they are primary users of PACOS. They're the ones that actually process the enrollments. NPES, as you see at the bottom middle here, is a system that assigned to NPI. And so you'll see in PICS here, the crosswalk system is introduced in between to map the NPIs to the legacy identifiers. And those legacy identifiers are now coordinated with the claims processing systems that are used in the MACs so that they can continue to process the claims using the legacy identifiers in place of the NPI. So when the NPI comes in on the claim, NPICS takes that NPI and crosswalks it to a legacy identifier or a series of legacy identifiers, and then sends those legacy identifiers associated with that claim to the shared systems, and the shared systems can now process the claim because they understand those legacy identifiers.
Okay, and if you want to know more about the NPICS processes, data flows, we have a module that focuses on NPICS that will give you a lot more details around that. Okay. Go ahead and mention what you want to do with this real quick here.
So we're not going to drill down right now on the data model itself. This will be unpacked for you in a subsequent training session. As the purpose here is the key table in NPICS is the provider identifier table that lists all of these legacy identifiers. And as you can see, associated with that is a number of other attributes. The next slide gives you the two key tables in NPICS. Provider identifier table, which lists all these legacy identifiers. And then the one on the right is the XREF, the crosswalk table, that links the NPI to each of these legacy identifiers. So we'll unpack that for you further in a future session.
Okay, break. Okay, so want to cut it there?
We'll cut it there.
Okay, we'll cut it there.
And then we
Cut it
don't
there.
need to talk about
So we'll
this.
come back and, yeah,
Okay.
we'll finish up these. Yeah.
Now, we could mention these last two or three just briefly.
I think you just cut it.
Yeah,
Okay.
it's good.
Yeah. So we'll come back and we'll do these.
On Monday.
Yeah.
Okay.
Yeah.
So when do you want to schedule this? Do you want to do it again Friday, or do you want
I
to?
can't, I mean, it looks like it was some time during the week, like a Wednesday and Thursday that was available, so I can work with you and
Okay.
we can find out the schedule
Okay, we
and
can
kind
find
of
out
go from there.
the best is.
Yeah.
Is this about the right level of detail? Do you
I think
feel
so. I
like
think it
it's-
was perfect.
it's
I
okay.
think, if we had a little bit more time, we probably could get it done. I don't think it was too long.
Yeah, I probably went a little lower than I could have. on
But the
many of
good
these.
news is we can edit some of this,
Sure.
and
Yep.
if we have to edit it down, we can.
It'll work out. So yeah, thanks a lot. I appreciate it. It was very good.
Yeah,
Yeah.
apologize when I'm given a
It-
microphone, I just, the train of thought just keeps going and I
Yeah,
can't
it's all
stop
right.
myself.
It's all right.
If I just read the slides, it might be.
It's all right. It was perfect. It was
It's all right,
very
Carter.
professional.
No.
So thank you.
So
I
anyway,
appreciate that.
Hopefully it'll be enough of a teaser that people will want to know more.
Well, I think it was a couple funny bits in there.
There's a
where,
lot
you know,
more could be said, obviously.
Yeah, sure. Absolutely. Hey, thanks a lot. We
Yeah,
appreciate that.
thank you.
Yeah.
Appreciate the opportunity to do this.
John, thank you.
Yep, no problem.
Appreciate it
Yeah,
very much. Thank you.
glad it's working.
All right.
Yep.
So any complaints go to John, all the accolades go to us. So, so we have division of labor going on.
That's a given. That's a given. That's
Why
right.
was it like this? I'm like, oh, you got to talk to John.
Talk to
Oh, it was so
John,
great.
yeah.
Talk to Carter and Ramesh.